together we have a challenge. That challenge is to bring down tobacco consumption rates in Aboriginal and Torres Strait Islander communities. From their current level of about 50%, we want to halve them by 2018. And we need your help to do that. Not only in terms of educating people about the benefits of not smoking, but making sure people understand the benefits of good and healthy food and exercise, and regularly seeing their doctor. These are important messages we want you to deliver for us, and thank you for doing it. Thank you.
And thanks, Minister. Hello, I'm Norman Swan. Welcome to this programme on reducing smoking amongst Indigenous people in Australia, funded by the Department of Health and Ageing. Smoking is the main contributor to the life expectancy gap between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. Tonight we'll cover the best evidence-based strategies on prevention and smoking cessation in Aboriginal communities, particularly in the light of a new and large government social marketing campaign. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Let me introduce our panel to you. Sean Appo is a Regional Tobacco Coordinator from the Tharawal Aboriginal Medical Service. Welcome, Sean.
G'day, how are you going?
We're going well. Sean has worked previously with the Aboriginal Health and Medical Research Council of New South Wales and the Sachs Institute, also in New South Wales. Rowena Ivers is a general practitioner and public health physician who's been working in Aboriginal health for about 20 years. Welcome, Rowena.
Thank you.
Rowena has been involved in smoking cessation programs in Aboriginal communities in the Northern Territory, North Queensland and New South Wales. Tony Mason is the Aboriginal Project Coordinator at Quit Victoria. Welcome, Tony.
Thank you.
Tony works with the Victorian Aboriginal and Torres Strait Islander communities, provides smoking cessation training and adapts Quit resources, as you'll hear later, to make them more culturally appropriate. Jasmine Sarin is the Senior Project Officer for Tobacco Resistance and Control at the Aboriginal Health and Medical Research Council in Sydney. Welcome, Jasmine.
Thanks, Norman.
Jasmine's previous work includes the Clean Air Dreaming Project of the Illawarra Aboriginal Medical Service, and we'll hear about that later as well. Nick Zwar is Professor of General Practice in the School of Public Health and Community Medicine at the University of New South Wales. Welcome, Nick.
Thanks, Norman.
Nick has had a long involvement in smoking cessation and in research and practice, including contributing to the smoking cessation clinical guidelines for the Australian College of General Practitioners. Welcome to you all.
Thank you.
Let's take a look now, before we get on to the panel, at the television ad that's going out from the Department of Health and Ageing, and they've produced it as part of the Break the Chain campaign to highlight the health impacts of smoking in Aboriginal communities.
I watched Pop die. Lung cancer from smoking. Mum had a heart attack from her smoking. My sis and Uncle Barry have trouble breathing. Rosie next door had a stroke, and doctors said it was from smokes. I was smoking for years too, but I quit. Because I don't want our kids growing up thinking disease and dying like that is normal. If I can do it, I reckon we all can.
Authorised by the Australian Government, Canberra.
Pretty impactful. Tony, any idea of the impact that those ads are having on Aboriginal communities?
I think it's generated a lot of discussion amongst the community, and I think everyone's excited to see that we have an Aboriginal person on the ad, so it's certainly thought-provoking, and whilst we haven't been able to draw data yet from our quit line, I think it's going to be fairly positive to get people thinking about changing their behaviour.
It's different from the non-Indigenous community ads, Jasmine, which tend to sort of scare the hell out of you by showing you suppurating lungs.
Definitely. I don't think that the scare tactic works as well anymore. I think people are moving away from fear-based campaigns and looking at something a bit more positive. Community and family, Sean?
Definitely. I think that's where some of our biggest gains can be made, by sort of accessing people or getting their emotions going through their families. That might make them, if they can't quit for themselves, then maybe they can quit for their families.
I think addiction is a huge factor for a lot of people as to why they smoke, and that's what we need.
It's kind of post hoc, though, isn't it? That's kind of after the event.
Yeah, it is a social norm for a lot of people that there is, encouragement to smoke and pressure to continue smoking. Those people who try to have a go at quitting seem to be knocked down by others in the community and say, no, you'll go back to smoking, just have another cigarette. So, there's that addiction, but also the social norm that needs to be challenged as well.
Jasmine?
I think a lot of people are very aware about the health effects of smoking. I think the thing that keeps people smoking is that idea that it relieves stress, and they use it for stress management. That's probably been the biggest factor.
So it's not a knowledge gap. Presumably you could go into any Aboriginal or Torres Strait Islander community in the country, ask anyone, young or old, they know that smoking is bad for them.
Definitely.
That's not the gap. It's not a knowledge gap.
Nope.
It's an action gap.
Yes.
And there's all sorts of other stuff. Your take on it, Sean?
I think there are some knowledge gaps.
Like?
Well, I just think that there is some old health promotion information that's still out there. Like one of the big ones that I have heard about, I probably haven't seen as much, was there was some about smoking during pregnancy. So there was one that said smoking gives you a smaller baby or something like that, wasn't it? Or if you smoke during pregnancy, you'll have a lower birth weight baby. So I think that was kind of flipped on its head by some people, and they thought, well, if I have a smaller baby,
I'll push it out more easily. This is a good thing.
To have a baby. So I don't know. I just heard about that.
The law of unintended consequences, as they say.
Yeah, absolutely.
So it's but basically we're talking about people nested within their communities, and Rowena, I mean, you've got a lot of experience here. We're talking about treating communities, not just individuals here, probably more so than in non-Indigenous Australia.
I mean, I think the thing to really remember is that over the last 20 or 30 years, there hasn't been any quit smoking programs, especially in remote areas. I mean, in Aboriginal services, a lot of the things that can help people quit smoking have been inaccessible, and people have been unable to afford them, and there basically haven't been any quit programs around.
What's the story with socioeconomic determinants in smoking, Nick, as a determinant here? Because there's only a limit to what you can do about that, and you can sort of throw up your hands and say, oh, let's give up. It's all about poverty, and I'm not demeaning the issue here about poverty and dislocation, but is that a driver?
Oh, it certainly is. And there is a gradient between socioeconomic status and smoking, with people from lower socioeconomic status tending to smoke more. What's been kind of pleasing about Australia's response to the tobacco challenge is that as prevalence has gone down, it's gone down generally about the same rate in higher SES and lower SES. And I think one of our challenges, with the exception of Aboriginal people, and one of our challenges is to keep that, build that equity and make it more, improve on the equity, and really not let that divide grow. So that we have a wealthy group, or relatively wealthy group, who are non-smokers and less well-off people who are smokers. But smoking is to some extent about choice, but as Rowena said, it's also about opportunity to get help to do something about it.
Rowena, we live in a nation where in the non-Indigenous community, I think we're the world's lowest smoking rate, or getting pretty close to it. How does it rate for, what are the statistics for Aboriginal communities?
Well, the prevalences in mainstream Australia have now been, they're now really under around 20%, about 17% for women and about 22% for men. For Aboriginal people, it's about 50%. But let's remember that in some areas around the country, it's actually about 70 to 80% in some parts of, say, East Arnhem Land. It's encouraging to see, and it's only a fairly recent trend, between 2002 and 2008, we're starting to see a drop among Aboriginal smokers, and it's the first time we've seen this. It's come down from about 51% down to about 47%. So that's really very encouraging, and that means that I think the effort that health staff are making is really having an impact. Certainly there's a few differences between urban and rural and remote prevalence for Aboriginal people, a little bit higher in rural and remote areas. There's also some differences in some areas between men and women. For example, in Alice Springs, a lot less women, in that area, a lot less women smoke. And also some differences in the type of tobacco used. In some areas in Australia, people actually chew tobacco instead of smoking tobacco.
So Tony, do we know why, apart from rurality, if I can get that out this time, apart from rurality and remoteness, do we know what other factors determine a high prevalence of smoking versus a lower one in Aboriginal communities? What are the key turning points or issues?
I guess we get a lot of responses when we do some training in the Territory and Victoria in rural areas where, there's high rates of unemployment and there's a lot of boredom, and a way of filling in time is to smoke. And because
so it comes back to Nick's point about socioeconomic determinants.
Yeah, and so you're bonding and sharing experiences with other people through smoking. So there's a whole lot of factors that come down to it, but once again, it's the resources in those areas that are key to helping people or encouraging people to change their behaviour as well.
What's the contribution to the life expectancy gap?
Well, you know, a lot of stuff coming out from the Commonwealth at the moment puts it at about 20%. It has to be higher than that because, you know, if you've got 50% smoking rates, then you would think that it would, the contribution that smoking makes to that shorter life has to be a lot higher.
I mean, I think the figures are, Nick, a pack a day at the age of 20, if you don't stop, that's 14 years off your life. 2 packs a day is 19 years off.
Yeah, it's around that. It varies a bit for men versus women. But yeah, and if you keep smoking past age 45, you've got a 1 in 2 chance of dying of smoking-related disease, and for Aboriginal people that would be even earlier than that. So yes, it would seem to have to be a big contribution to that gap in life expectancy, would be tobacco.
And Jasmine, just going back to the impact, presumably the impact's there on children as well, because you're seeing asthma and respiratory disease in children from passive smoking.
Definitely. In the past, there hasn't been a lot of promotion about, you know, smoke-free cars and smoke-free homes. You know, but that's been changing recently, especially in the last, I'd say 5 years or so, where it's now legal to smoke in cars with children under the age of 16. You know, a lot of people sort of forget that environmental tobacco smoke is harmful to, you know, growing minds and growing bodies, and can actually, you know, lead to, you know, young kids sort of taking up cigarette smoke and, you know, becoming addicted earlier.
So the age of initiation is a key statistic here. The younger you start any drug, you know, Aboriginal or non-Indigenous, the more likely you are to be taking it at harmful levels. So what's the age of initiation in Aboriginal communities compared to non-Indigenous Australia?
I think it's quite low. It's kind of between that sort of 8 to 10 age group. The reasons for that, I don't quite know in my own community. It's certainly something that we'll be getting around to trying to find out.
But you know, partly what Jasmine's saying is you see so much around that there's believed to be no controls on it. Just tell me a little bit about these recent government initiatives, because everybody might not be fully aware of what's going on here. Because it's quite, I said it's, you know, a government ad campaign. It's far more than that, isn't it?
Yeah, so there's an Indigenous chronic disease package that had been announced a few years ago, and so there is a huge workforce that's going out across the country that includes tobacco action workers and healthy lifestyle workers. But in addition to that, there is the social marketing campaign, but also a quitline enhancement as well. So every jurisdiction will be working towards increasing calls to the quitline from the Aboriginal community.
Tell me about the social marketing campaign.
Well, I guess social marketing is just using new technologies to get health promotion out into the community. So there's quite a few things that are out there now. As Tony mentioned, the Break the Chain has just come out. Some of the other resources that are on the screen there now are some of the health promotion that different communities have developed around the different states. There's also some resources there that help people and help services to develop their own health promotion and social marketing. There's videos on YouTube from places like Me Watch Health Centre. There's been research done.
There's also Facebook, isn't it?
Facebook, yeah. I mean, you have to fish where the fish are, and there's certainly lots of Aboriginal community people are on Facebook. So why not try and get the information across to them there?
Facebook's almost made for Aboriginal communities, isn't it?
Well, let's hope so, because it's definitely one of the strategies that we're trying to use down at Thurrowool, and it's been going pretty well. Like, if we post something up on Facebook, within about 2 or 3 days, we can see that, you know, 100 people have looked at that. If we wanted to do that the old-fashioned way by doing health promotion presentations around the community, that might take us 3 weeks to reach that kind of number.
We've got questions and comments coming in. Peter Bowman from the Tiwi Islands asks, you can separate out 2 categories of smoker who should quit: smokers who already have chronic disease and smokers who are as yet healthy. The first category is, of course, a priority medical problem for doctors, nurses and health dollars. But the healthy category is huge. To make any headway here requires resources far beyond what any health budget offers. And it is a social rather than a medical issue. Are there any thoughts about building workforce of health educators to tackle this, with the budget coming from community resources other than medical? I suppose that's my cue to ask you what these new tobacco workers in Aboriginal communities are doing. Almost on cue. Thank you, Peter Bowman.
Yeah, fantastic. Well, we're trying to develop networks in our community, so with other service providers and also through our community, so other sort of important community members. So if we can sign up like this small local army of local champions, if you like, so people who don't smoke, those local role models, if we can find some of those and work with them to find out what it is about them that stopped them from smoking in the first place, and then use them to work within their spheres to sort of get the information out about, you know, not smoking. We're also trying to customise a lot of the information that's already out there. So a lot of the mainstream information is quite useful information, but it's just in a format that hasn't seemed to have worked for Aboriginal people over the last 30 or 40 years since those kind of campaigns have been done. We also, you know, mobilise community resources, so hold events where we can promote healthy messages as well as, you know, just get people in to have a bit of a good time. And we want to try and deliver quit smoking support to people, whether they be individual support or in quit groups.
And Jasmine, what are you doing about role models more explicitly? I mean, in non-Indigenous communities, you've largely got the benefit when you go and see a doctor, you know the doctor doesn't smoke.
Yes.
It's unusual. Whereas it's normal for an Aboriginal health worker to smoke. And they smoke at the same rate. Some people even argue at a higher rate than the general community. What's being done to help support Aboriginal health workers who are under a lot of stress themselves, with a lot of conflicting demands in the community, to stop themselves and if you like, lead the way?
I think there's a little bit of research being done at the moment around looking at Aboriginal health workers and their own tobacco use. The big issue is their own personal use being a barrier to providing brief intervention support to their clients, especially when the clients know that they themselves are smokers as well. So they don't want to come across as being hypocritical. What we've been looking at is trying to look at ways that Aboriginal health workers can feel comfortable in discussing either their own, you know, tobacco use with their clients. We're trying to look at developing workplace practices to help Aboriginal health workers quit smoking. There's a lot of incentives from some of our AMSs, whether it's you know, they get to leave half an hour early on a Friday because, you know, they're not go out every 5 minutes for a smoko break and things like that. I've also heard of some AMSs giving like a bonus if they quit. If they quit for 10 weeks or something like that, they get a bit of a cash bonus, which has been a really good incentive. So,
Tony, what about a rules-based approach? I was asking Sean about this earlier as well, but a rules-based approach, because that's what's worked in non-Indigenous communities. You know, you shall not, you're just not allowed to smoke in the restaurant. You're not allowed to smoke in the workplace. This is by law, legislation. You know, you just get tough on smokers. What about that approach in terms of Aboriginal communities and workers?
I think it's not. It's not necessarily telling smokers that they can't smoke, but it's just protecting people who don't smoke as well that might be in that space. So, in particular for an Aboriginal medical service, everyone's going there to get healthy, and they're walking through the smoke screen. So I think you know, we need to see much more solid smoke-free policies implemented into some Aboriginal medical services, and lots of people do have them. It's just communicating the rules around those policies to make sure that everyone is aware, because you know, the Aboriginal community is transient, so you might be walking into a service that you don't necessarily know the rules and regulations, and you don't want them to be told off and never come back. So it's important about communicating that.
It is, yeah. I guess one of the things that we're looking at doing as well is working with some of the other services in our community where our Aboriginal community go to, so that message, that sort of policy is seen to be community-wide.
Yeah.
And so they're always getting that constant message about, you know, smoking is harming health, so try to quit.
Sean, you've brought one of your ads along with you. Talk us into it.
Talk you into it.
This is like, you know, your latest song, Sean, but you know, in your case, it's an ad.
It is, absolutely. Well, I guess what we're trying to do is use those new marketing technologies to get the people. I think, you know, posters and pamphlets have been done for quite a long time and don't seem to have had any impact. Yeah. So what we're trying to do is provide health promotion in a way that's going to get the message across that people are going to look at.
And you're showing this on local television? We're
going to go and try and get it with a local community television station in Sydney, yes.
Let's have a look at it.
Smoking has many costs to your health and your family. But have you considered how much smoking also costs you financially? Smoking 10 cigarettes a day adds up to almost 3 packets of 25 each week. That would cost around $45 each week. If you multiply that over a year, that adds up to $2,340 a year on smokes. Stop your money from going up in smoke. If you added together the financial health and family costs of your smoking, can you afford not to quit? Make an appointment today to speak to our tobacco action worker or a GP. Call 4628 4837.
That. Good luck with it.
Yeah, thank you.
Let's take a quick look at our next case study, an example of a brief intervention using the smoke check program.
I work for ATODS, which is Alcohol, Tobacco and Other Drug Services. I'm the team leader of ATODS and mental health here in Cherbourg. We identified through chronic disease, through community health, that there was a big need to do something about the smoking within the community. We had some staff members go away and do training on smoke check program, and we've been delivering it here in Cherbourg since June 2010. We do a lot of health promotion, which gets the message out to the wider community. We have health days in the park where people can come and participate in the smoke check program.
The smoke check program is very culturally appropriate. It's a brief intervention and it's certainly very acceptable here in the community.
Hello, how can I help you? I'm here to see Robin about a smoke check. Just a minute, I'll get Robin for you. Thank you.
I met Linda at the Health Promotion Day at the hall a few weeks ago. So it's really great that she's coming in now and is seriously trying to give up this time. Yeah. This first stage is I'm not ready to stop. I really like my smokes. So I think
I'm past that stage.
You're past that. I'm not sure about it if I'm ready to stop.
Yeah, I'm in between, unsure. And then half of me is saying I'm ready to give up.
Yeah, so that...
But I really do want to give up.
So you actually it's very visual and gets to the point. People can recognise instantly where they're at with their smoking. We try and look at all the positive aspects. And we always congratulate people on doing that because a lot of people take up to 20 times sometimes to give up before they finally give up. So hopefully it's not as long as that for Linda.
Well, I got children, so yeah. I want to be around longer. And the way I smoke, I don't see myself seeing them grow.
The smoke check program works really well as a catalyst for people to think about giving up. They often require a lot of support and assistance to do this. So
this smoke check program is designed for Aboriginal people. I believe it is a lot better than just handing somebody a bit of paper, because papers they don't necessarily read. Everybody gives pamphlets out here, so you know they're good fire starters. That's about it.
Now Susie's drawing her cigarette in.
We have more visual aids through the smoke check, which is something that Aboriginal people identify with. We have a lot of visual aids that we take to the schools that the children love, a bit of gooey stuff and that, so they love playing with it. It's more or less just to educate young kids on the harmful effects of smoking to their health, and through that hopefully the message is getting taken home.
So what do you see about the good things about giving up smoking?
I have more money in my pocket.
Certainly, yeah. They say you can save up to about $5,000 a year.
Yeah.
So would you like to have this pamphlet? It's written for people who are ready to give up smoking.
Yeah, it'd be good. I'll read this.
What are some of the things or ways that you coped then when you gave up before?
I stopped smoking in my house.
Yes.
People that come there, they don't smoke in my house anymore.
Yes. What about that early morning cup of tea and the smoke?
Yeah, that was the hardest part of giving up.
So how did you manage that?
I used to drink coffee with it, so now I drink tea.
Okay, and do you still sit in the same place?
No.
You don't?
No.
You sit somewhere else?
Yeah.
So that's a really good step because it's about habits, isn't it?
Yeah, it is.
Yeah.
So we're from here.
Okay,
After
so...
you do this, what happens then?
Okay, so we'll have to, perhaps we can develop a plan about when you're actually going to stop.
Okay, yeah.
Your stopping date, and work around that plan.
Okay.
Yeah, and also I think it would be a good idea to have a health check with the doctor and get the patches at the same time, and that way we can monitor your health as well.
Okay.
So next time you come in, we'll go over a plan that suits you.
I do believe the program is making a difference within the community. I think because of all the information that we have been giving people one-on-one, that the message is sinking in to live a healthier lifestyle, and giving up smoking is one of those.
Seems like a good program, Jasmine.
Yes, it does.
What's going to help someone like Linda move forward?
In my experience, I think having that person that you can go to for support, especially if there's no support at home, having someone to sort of sit down, talk with you about, you know, how your smoking's going, to help you identify some of the things that you can change early on. Yeah, it's been pretty good.
I mean, Rowena, I suppose it's just one person at a time here. And you expect that you get one person, particularly a woman, stopping smoking, she's going to guard her house and make sure that's smoke-free, so it actually could have a mushroom effect.
I think it's always going to be an individual's decision to quit smoking, but I'd like to see with the programs that are going on in communities, there can be community interventions as well. And I guess our role as health professionals is to help people at individual intervention, but then to branch out into the community and be able to do other things as well.
Tony?
Yeah, I think it's good to also talk through some strategies about how people can avoid smoking, or encouraging them just to have a practice at quitting and just see how they go. And then
do you give
building
them a
on that.
practice about how to tell their husband to get out of the house when he wants to have a fag?
Yeah, it's or just keep it to the kids. It's if that's easier to encourage people not to smoke in the home.
Appeal to altruism. Yeah. So, Nick, what are the elements of a brief intervention that we need to be aware of?
Sure. Well, I think we saw a lot of them in the case study. Asking. We've got to identify and be willing to ask about tobacco use.
This is the 5 A's that you're going to...
Yeah, this is the 5 A's, yeah. Ask, because we need to both identify smokers and document tobacco use as health professionals, and be prepared to ask at quite a young age too. Clearly that's very important in Aboriginal people, given if they're starting smoking at age 8 to 10. Assess, and we saw again that in the case study, we saw the assessment of their interest in quitting, the stage of change idea. And another aspect is nicotine dependence. Is this person nicotine dependent, and if so, to what degree? Advise, making it clear as a health professional that we think that it's really important that this person stop smoking, and we'd like to help them to do it. And then offering assistance, and again we saw in the case study that was being tailored to that person's interest and what was right for them and might help them. And that's a lot about motivational approaches and trying to come up with a plan in a partnership. And assistance often involves a medicine as well if a person's
we'll come to that in a minute.
dependent.
There's controversy around this stage of change and motivational interviewing, isn't there?
There is indeed controversy about that. I think the stage of change is quite an unpredictable thing. You might see someone, as we saw in the case study, who's interested at that time, and you really want to kind of move forward on that if you possibly can, because something might happen, and then 2 weeks later, you know, that maybe there's been some problem in the family, maybe there's something else going on, and that priority has been pushed off the agenda. So the stages of change are not always predictable. People don't always move through each one in turn. But it can be a useful tool, and is a useful tool for a health professional to say, okay, this is how you feel about smoking at this point in time, and this might be what might help you in terms of both support and, you know, and a plan of action.
What do we know about comorbidity? There's a question here from Laura from New South Wales asking, do you think there's a link between smoking and alcohol use?
Well, there is, definitely. There's higher rates.
Can you treat one without the other?
Well, it's a good question. I think you can treat one without the other. The difficulty that I think that people have with alcohol and smoking is that if they're drinking, particularly if they're drinking excessively, it does trigger some of the same parts of the brain, and and also willpower tends to suffer when you've had some alcohol. So often people are suggested to at least cut down their alcohol use if they can't abstain in a quit attempt.
Rowena, Tony from the Remote Area Health Corps asks, are there any differences in smoking rates between dry and wet communities? Do we know that?
I'm not aware of any evidence, but again there is a link between alcohol and tobacco. So yeah, I'm sure that would apply.
Anybody else know the answer to that question? Just
I don't actually. I know you hear people talk about...
I mean, some people might argue there's a trade-off. You go dry, the smoking rates could potentially go up.
I've certainly worked in remote communities that are dry, that have smoking rates of 70 to 80%. So, yeah. It's
independent.
Yeah.
You've just got to deal with both at the same time. Do we know what people use to give up, Nick?
Well, I use a range of strategies, but the most common one is not using anything at all. And I think we've got a graphic on that. This was some work done by the National Drug and Alcohol Research Centre asking people, in your last quit attempt, what approaches did you use to help you quit? And the striking thing was that 88% of people, that's that blue bar on the left, hadn't used any form of support. They'd just gone so cold turkey. So they hadn't gone to a health professional, they hadn't phoned the quit line, they hadn't used nicotine patches. And so that is the most common approach, is to just try on your own. And for some people that works. But certainly support and assistance can make you more likely to succeed, and would like to make that available if people would like to use it.
So tell me about the pharmacological interventions.
Sure. Okay, well, again, we've got a slide, I think, just summarising what's available. There's nicotine replacement therapy in various forms. Of course, there's the patch, and there's other shorter acting forms like gum inhaler, sublingual tablets and lozenges. There's a medicine called bupropion sustained release, and there's a medicine called varenicline. And all of those are now available on the Pharmaceutical Benefits Scheme for both Aboriginal people and for the general community.
And actually I might just raise a point there for Aboriginal people around Australia. There's a new scheme that started last year called the Close the Gap scheme, which means that if Aboriginal people sign up with their mainstream general practitioner or Aboriginal medical service, they're actually able to access either free pharmaceutical benefit scheme medications or discounted medications if they're working and don't have a healthcare card. And that's made a huge contribution to the affordability of pharmacotherapies, and I think it has made it a lot easier for Aboriginal people, Aboriginal and Torres Strait Islander people, to make a quit attempt using those pharmacotherapies.
Sean, you feel that the message is not necessarily getting through about those, particularly to some pharmacists?
Yeah, look, the last couple of times I've gone to the chemist to try and get some asthma medication, on the top of my script it's got CTG written there, which is what GPs and GPs who work in AMSs have been asked to do. So you go along to the pharmacist, you give them that, they come back with your script and say that'll be $30, and you go, well, actually it's part of the Close the Gap scheme, and if you go to the PBS website you can find the information. And so I've actually had to try and help them out there a little bit, so I don't know how much the information has filtered down through the systems to those pharmacists.
So talk me through those various, the pros and cons of those various pharmaceuticals.
Sure, and I think again we've got another slide here just looking at the process of how you might choose which medicine to use. It's based really on clinical suitability and patient preference. So there's not really one medicine that stands out as being that much better than the others. So, the nicotine replacement therapy, varenicline and bupropion all work to a degree, and they work roughly equally well, So really it's whether there's a reason to prefer one in that patient, and that might be for a clinical reason, like there might be a contraindication to use one of those medicines. For example, if someone has a history of recurrent depression, we don't know that varenicline is safe in those people. If someone had a history of seizures, you wouldn't choose bupropion. So there's some things like that. And then there's patient preference. Some people prefer something that they take as a tablet, and others prefer the idea of using something like a patch or, instead. So, and cost certainly comes into that as well. That's definitely a factor.
How much additional help does a pharmacist... Some people would argue that the additional assistance you get from either pharmacotherapy or nicotine replacement is so small as to be not worth the effort.
The additionals...
in other words, over just going cold turkey.
Yeah, well, if you took 100 people who tried to quit cold turkey, so-called today, no support, either of any kind, you'd have a year later about 3 to 5 would still be quit. Okay, so only a small number successful, unfortunately. But if you took that same 100 people and they made use of a medicine and some support, then it might be around 20 to even 30 of those people. But it's not everybody, but it's certainly a big difference in outcome.
Did you want to say something, Rowena?
I think another factor is nicotine replacement therapy for pregnant women. I guess that's another thing that it can add to the quit rate there too. We don't really want to use, I think trying to quit without any cold turkey is often advisable first, but people can use intermittent therapy like lozenges or they're probably not patches, but that's also still available.
And how much additional help from counselling, given that a lot of people will just be taking the nicotine patches or the medication?
Yeah, sure. I mean, I think that it's hard to disentangle. There's some evidence that nicotine replacement without counselling still has a measurable effect, a useful effect. That hasn't been proven for the other medicines because all of the studies have been along with counselling. But there is evidence that even without support, the medicines make a difference, or certainly nicotine replacement makes a difference. But it's a lesser difference. You know, it's not as big a benefit as if you do get some support as well.
And what about contraindications?
Well, there's a number, and people, of course, would need to look up the information about each medicine, the prescribing information, and there's information in some of the resources we're going to mention. But as I said, you know, with nicotine replacement, there aren't very many really contraindications except if you're allergic to some component of the medicine, or if you've just very recently had a heart attack, you'd be quite cautious about using nicotine replacement. But really, as I think Rowena was alluding to, it's hard to think of any example where it would be safer to keep smoking than to use nicotine replacement. I mean, it's got to be better to stop smoking.
Emily asks, and from New South Wales, asks you, Sean, in regards to the lack of knowledge being passed to pharmacists, is this a reflection of the lack of support from the government? What are they doing to help?
That's a really difficult one. I think unless pharmacists are coming into contact with a lot of Aboriginal people, it just might not come across their radar. So it could be either of those things. So I guess it's up to health workers and so even some of the GPs who work in areas where there aren't Aboriginal health services to get in touch with their pharmacists to make sure that they know about this kind of support that the government's trying to offer.
What's been the uptake of nicotine replacement since the change in the scheme? Jasmine, you know that you can now get these on PBS.
I think there's still a lot of myths around the use of NRT. I think, and you can catch it quite early if you're coupling that with counselling. A lot of people still think that as soon as you put the patch on, it's going to start working straight away. And we've had a couple of issues with using pharmacies. Clients gone down and the pharmacist has refused to give them multiple NRT or combination nicotine replacement therapies. But in terms of the PBS, I don't think people have taken up as much as they can.
Yeah.
And I suppose we need to set expectations here that Rowena, this takes a lot. You can take a lot of attempts before you're successful. Don't give up after the second or third time.
That's right. I mean, I think most smokers take about 6 or 7 attempts. I mean, in the mainstream, actually, it's looking as time goes on, as some smokers are making, up to 20 attempts. But some of the research from Aboriginal communities is that lots of people might have only made a couple of attempts. So it is about just encouraging people to try and try again, and to expect that it's probably going to take a few times and a few attempts before they're actually successful. But to keep on being very positive and giving support for each of those attempts.
Tell me about the college guidelines.
Yes, there's guidelines about smoking cessation which the Australian government funded back in 2004, and that's this document, and available both on the RACGP website and on the quitnow.gov.au website, and there's those websites. And as well as that, there's also a pharmacotherapy update which the College of GPs produced firstly in 2007 and has been updated a couple of times since. And this is just a fairly brief guide about, particularly focused on the medicines and how they could be used and how they fit and all the things we're talking about to do with contraindications and how you might make an assessment about which medicine to use.
Summer from Finley asks, stress, anxiety and depression make quitting more difficult. What do we need to do about mental health to effectively tackle smoking? Rowena?
Certainly among our clients with mental health problems, smoking rates are much higher. I think we tackle both at the same time, and certainly I think in the Aboriginal Medical Service where I work, we would be giving them help on their psychological issues as well as help on their smoking.
Jasmine?
Yeah, I agree with Rowena. I've worked with Rowena at Illawarra Aboriginal Medical Service, and a lot of the time, opportunistically mainly, I'll catch clients coming, who've seen Rowena, and we'll sort of couple up and, case manage any other issues that they have as well.
What's the nature? Sorry, Sean, you want to say?
I was just going to say, I think we also need to disentangle, nicotine cravings from stress. Somebody can be feeling as if they are really stressing out, but what they're actually having is they're craving that new shot of nicotine. So,
what are the withdrawal effects of nicotine, Nick?
Well, as Sean just said, cravings the most that's the kind of most common one. I mean, it's a drug withdrawal state, so people crave the drug. But also people often have a number of other symptoms, and they might have 4 or more of those things you can see there. Depressed mood, insomnia. Irritability is a really common one. Crankiness, irritability, frustration, difficulty concentrating, restlessness, you can see, and heart rate changes and appetite. It doesn't go on forever. I think that's important. It often starts sometimes with really dependent smokers, even a few hours after their last cigarette, and can last up to 4 weeks. But it typically lasts about 2 weeks. But our aim with the medicines, of course, as people were suggesting, is to not have people go through that. They don't have to. would like to stop that being necessary.
And in terms of the evidence base, what's the nature of the counsel? What do you do in counselling that works?
Well, the things that seem to help, and it's not kind of rocket science, the thing that seems to help is helping people to set a quit day, helping people to be motivated to make a quit attempt. That's probably the main thing that health professionals do is encourage more quit attempts. Helping people to get social support, encouragement, and encouraging people to keep trying and feeling there's someone on their side. Helping them with some problem-solving things, how they're going to cope with, cravings, how they're going to cope if they get, drink alcohol, how they're going to cope if they have a little lapse or a slip, how they're going to get, refocus on their quit attempt. And seeing people for that ongoing support, as we saw in the case study, where they've got someone that they can talk to, someone who's going to be there for them going through that process.
Well, being on that, in that situation where I've had to provide, that type of support to a client, sort of setting them up for, what they might experience when they're going to go through their quit attempt. A lot of the clients I had either hadn't made a previous quit attempt or had made very little, and mostly did it cold turkey. So it was really good to sort of sit down and go, okay, this is what you might be feeling and this is what you might experience. And if you do experience these things, these are what you can do, to help get you through that situation. And instead of, I had a lot of clients freak out about setting a quit date, that it sort of, made them more anxious to do it. So we had a look at just doing small things like cue conditioning, so changing those everyday habits, getting them to pick out the cigarettes that were sort of crucial in their day, so that morning cigarette or the one after dinner, and saying, okay, when you get up in the morning, make your cup of tea or coffee, have that first, and then if you still feel like it, have your cigarette. Try not to do both of them together and try to separate those actions.
Give us a sense of the resources that are available for people watching.
So there are a few resources out there already available. There's the Smoke Check. We've got Smoke Check New South Wales, Smoke Check Queensland and Smoke Check South Australia. So this is the manual you get when you complete their training. It does contain brochures on the 5 steps, the stages of change. Also the Talking Up Good Air kit from CETSI, which has a briefing, which also deals with advocacy. Sort of gives you background information on...
This is the Centre for Excellence in Tobacco Control you're talking about, yeah.
So they also have on their website helpful links and other publications available. They have a project register, so you can check out anything that might be close by in your area to get in contact with. So it's a very good resource to have. And I think there are a few others available as well, Rowena.
Certainly the other guidelines that are available on smoking are, first of all, the guidelines on the preventive health check for all Aboriginal and Torres Strait Islander across Australia includes to giving advice on tobacco. In Central Australia, Western Australia and North Queensland, a lot of remote area health services also use the Central Australia Rural Practitioner guidelines, the CARPA manual, which also have very clear guidelines on giving advice on smoking and how to advise on giving some of the pharmacotherapies as well.
And don't forget the quit line, 137848. How do you tailor the quit line in Victoria for Aboriginal communities?
So really exciting stuff that we're doing. We've employed an Aboriginal liaison officer who will go out and start talking about Quitline and demystify it for the community and just talk about what the service will provide for their clients. But we've also employed an Aboriginal Quitline counsellor who will specifically speak to people in our community to encourage them to stop smoking and just have a chat about.
So do they have a different script if somebody identifies as Aboriginal?
I guess the counselling techniques would be a little bit different in terms of engaging with that client and building up trust and rapport. We'll also ensure that the caller will always have the same counsellor, so that way they don't get to speak to someone different every time, which is the current policy for mainstream callers.
Tell me about that Clean Air Dreaming project that you did in Dapto, Jasmine.
So the Clean Air Dreaming project we did at Illawarra through Illawarra AMS. Also did it at South Coast AMS and down at Katunga, which is in Narooma. So what we tried to do is create a program that offered a wide range of support. We could also offer free nicotine replacement therapy. And we had the use of making sure our GPs knew about varenicline and that was available on PBS. We offered a 4-week quit program that sort of looked through the stages of change. It looked through planning, having a quit plan, so how to deal with those high risk situations. If you're out with friends and you have a bunch of friends who only smoke while they're drinking, which I find is pretty common. How to deal with that situation. If you do find yourself relapsing, how to deal with that, and sort of re-promoting the message that if you do relapse, no one's going to get mad at you or putting the finger at you. Sort of get up, take a few things of what you learned and try again.
I'm just going to ask for a question from Jason from Muchopper and Health Service. Do you think that plain packaging will make a difference to smoking rates in Aboriginal communities? Sean?
I've been thinking about that for a while, because it's been in the news for quite some time now, and I actually think it will, because most of the packs that we see now, they're really visible. So, if one of your aunties smokes or something like that, then if her purse is there, or if she'll have the cigarettes on the table, a bright blue or a bright red will stand out quite a lot easier than some olive colour. So I think it'll be really interesting to see what kind of impact it does have, but I think it will sort of lower that visibility, which is what it's all about.
Shelley from Barwon has emailed us saying Oxygen is a great youth-specific tobacco control website and for resources.
It is. We've had a good look at that. It's more targeted towards youth, as she said, but there are some really interesting things on there.
We've also a question asked from Sue. What are the biggest relapse factors for Indigenous people who've quit?
Probably a crisis. Yeah.
And
not sure how to deal with that in any other way apart from smoking. So that's usually the big contributor to going back.
And presumably you just have to set expectations. If something like that happens, it doesn't mean that you've lost the plot. You can always go back to quitting after that.
Yeah.
One cigarette does not necessarily mean the end of the world.
Correct.
You've got a motivational device with you, Jasmine. Show us it.
So this is a PiCO smokalizer. So what this does is measures the amounts of carbon monoxide in your lungs. So it measures it in parts per million. So what happens is when you have a cigarette, you inhale carbon monoxide into your system, which is carried around by your red blood cells, which replaces the oxygen in your body. So the more you smoke, the more carbon monoxide, the less oxygen you will have. So this is a great unbiased tool that we've been using, and a lot of other AMSs have now taken up.
So is this your bullshit monitor, is it?
Yeah, it works pretty well. And you can use it with youth as well. So it'll give a reading, and it sort of, we'll place you somewhere on a chart, whether you're a non-smoker, a light smoker, an addicted smoker, and a heavily addicted smoker. So it comes in quite handy.
Keith from Cairns asks, I'm a physiotherapist working in Cairns to assist with cardiac and pulmonary rehabilitation. Where can I access the quit smoking literature specific to Indigenous clients? Tony?
There's lots of literature around. I think, the Centre for Excellence in Indigenous Tobacco Control has a lot of...
So it's those resources that Jasmine gave us earlier.
Yeah, and then there's also Tobacco in Australia, Facts and Issues, which is quite comprehensive and has a lot of information.
Right. A question from South Australia. Tony, what are the harmful components of smoking?
All the chemicals that are in tobacco. Yeah,
there's not much that's good.
No, there's over 4,000 compounds that are, poisonous, and 69 of them are known to cause cancer. So it's quite scary and that's in each cigarette, not per packet either. So there's lots of health effects.
Another question from Summer from Finley asks, the Close the Gap campaign seems to be focused on individuals and families rather than broad socio-economic determinants. And she's asking, how do you get the balance there? Does there need to be more done at a policy level?
The Close the Gap campaign also has funding for other broader factors that improve those socioeconomic factors. So it's also got funding for education programs in terms of closing the gap there, and in terms of housing funding. There's a wide range of programs. I guess on the tobacco programs, again, it's programs like Sean's. They're broader community tobacco programs, not just based on a one-on-one basis in the clinic.
Quickly move to a case study. Ruby's 26. She comes to see you, Rowena, at the local Aboriginal Medical Service with 2 small kids. She's concerned about their health. The youngest, Jimmy's 3 years old. He's got a discharge from his ear. Becky, who's 5, has a cough and a runny nose. And Ruby smokes 20 a day. What are you going to do?
This is a very familiar scenario. In fact, I've been in the clinic today, and we've probably had this scenario a few times over the last couple of days. Look, in an Aboriginal medical service, it's really a team approach. So a lot of the work is spread between Aboriginal health workers, child and maternal health workers, nursing staff and GPs. So certainly we'd be seeing the kids. We'd be looking at their ear problems and respiratory tract infections, but probably also doing a child health check at the same time. Now, a routine part of our child health check, and in fact a routine part when children present with illnesses that we know are probably related to exposure to environmental tobacco smoke, is to ask about tobacco. And so, and it's about addressing whether family members are smoking around them, and addressing the role of parents as role models themselves. So we might then sit down with Ruby and go through a health check with her. So again, it comes back to the 5 A's. We want to first ask her whether she's a smoker and record it on her medical records so people in the future can check on how she's going. We want to advise her strongly to quit and link it to her children's illness, because this is a time when she's going to be responsive to that kind of advice. We want to see whether she's ready to quit, assess whether she's ready to quit, and it might mean using some of those pamphlets we've shown tonight. And then we want to assist her in quitting. So again, it might mean signing her up for Close the Gap, and possibly certainly giving a brief intervention, possibly using some pharmacotherapies, and arrange follow-up with either the smoking worker or Aboriginal health worker or a GP or nurse.
So, Sean, just finally, people are all fired up at the moment. There's a lot of money going into this. It looks as if for once we're going to have targeted campaigns to Aboriginal people, which might make a difference. 200 people, I think, coming, working in your area in tobacco control around the country. How to maintain the fire?
Well, I think we've already seen smoking rates coming down, so I think that movement is happening. I think there are a lot of people who are smoking.
So the feedback to workers, the benefits of their work is going to be one of the things to maintain the energy.
Well, yes, but I think some of our workers could be doing more as well. So, I hear quite a lot that health workers, and I don't want to demonise health workers, they do a fantastic job. But one of the things we hear is that they don't feel comfortable talking to community members who smoke about their smoking if they also smoke, so they don't want to make hypocrites of themselves. And I would say to those health workers, look, it is our role as health workers, armed with the information about what tobacco does, to pass that information on to the community members so they can make their own choices. That's definitely one area where I think we can have a big gain in the next few years.
A couple of quick comments from our viewers. Nicola from Victoria asks or comments that general practitioners and others need to be aware of their Aboriginal patients and specifically target. I presume there's no barrier to asking, being able to identify people or self-identifying people in the community so that you know who's Aboriginal in your patient group?
It's actually an accreditation requirement for mainstream general practice to actually ask Aboriginal or Torres Strait Islander status for everyone across Australia when they're entering health services.
And one of the messages from tonight's programme is target the message and be careful of that. Maria from Forbes wonders, have rural councils been proactive in promoting smoking cessation? And it will be highly variable, Sean.
Some have actually. I think Cobar, their main street is smoke-free. So I think some councils have been quite proactive. Some of the urban councils probably could learn from some of the rural councils.
So what are your take-home messages, Nick?
Well, I think it's identify smokers and offer support. Try to offer that support for the things we know help, and not everyone will want it, and that's completely there. We respect that, but we would like to offer it and to try to have a partnership to help address the issue.
Jasmine.
Tobacco has been a big issue for a long time, and I think it's good to finally see the spotlight on it. So feel free to seek support or to offer advice if you're in those positions.
Tony.
I think a health professional should be not afraid to ask their Aboriginal clients about their smoking status, and certainly encouraging them to move through the stages of change and help them plan a quit attempt.
I would say that it's important for all health professionals, health workers, nurses and GPs to keep giving advice. It is making a dent in the smoking rates, and I guess as Warren Snowden said, we want to bring the smoking rates down by 50% over the next 7 or 8 years.
And presumably there'll be a threshold. You get to a certain point and it'll speed up, like it did in the non-Aboriginal community. Sean?
Look, I would just urge, if there are any health workers listening, just to try and support the people who are trying to make a quit attempt, just to try and raise their confidence so that they'll just keep trying and trying and trying until it actually sticks.
Thank you all very much indeed. It's been great. And we'd like to thank the Centre for Excellence in Indigenous Tobacco Control, SmokeCheck New South Wales and SmokeCheck Queensland for providing information and resources. We'd like to thank the Department of Health and Ageing for making the programme possible, and of course our panel members, but also thanks to you for taking the time to attend and contribute. Now you've got to tell us what you thought about the programme by filling in an evaluation form. And as always, if you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website. That's rhef.com.au. I'm Norman Swan. I'll see you next time.